This week, the Senate and House Health and Welfare Committees were scheduled to hear from medical professionals on the effects of Idaho's abortion ban on physician recruitment and patient care. Lawmakers ultimately canceled that hearing, but the problems still exist. On Friday, Dr. Jim Souza, Chief Medical Officer of St. Luke's, OB/GYN Dr. Megan Kasper, and the Idaho Medical Association CEO Susie Keller joined me on set to talk about their concerns. Thanks so much for joining us today. Susie, statewide, what's the situation on the ground?
Well, in February of this year, the Idaho Physician Wellness Action Collaborative had gathered some data that was published showing that between August of 2022 and November of 2023, we've lost about 50 OB/GYNs in the state. That's about 22% of our OB/GYN workforce. So that's had quite an impact, as you might imagine. We know from HRSA in 2018, they estimated that we should have about 250 OB/GYNs for our population at that time. And looking forward to 2028, they think we need about 275. So we're behind the 8 ball quite a bit.
So we've been losing these physicians too at a time when our population has been growing.
Absolutely, absolutely. And right now we have about 210 practicing OB/GYNs and about 975,000 women in the state of Idaho. That puts our ratio at about 2.2 OB/GYNs per 10,000 women. Nationally, the ratio has been about 14 OB/GYNs per 10,000 women.
Dr. Souza, what is recruitment like? What's it like trying to convince people to come here and work?
It's become much more difficult. Positions that we used to fill in a matter of weeks now are open for months, or they just go unfilled. And worse than that is we keep digging the hole deeper, so to speak. Probably the group of women's healthcare providers that have been hit the hardest by the fear and lack of clarity in the law have been the maternal fetal medicine specialists. You just heard from Susie about the OB/GYNs. These are the physicians with extra training who manage high-risk pregnancy and pregnancies with fetal complications. And we lost 5 of 9 in the past year.
Is that St. Luke's specifically or statewide?
That's statewide.
Got it. So more than half.
Yes.
Mm-hmm. Have these physicians said specifically whether they're not applying for these jobs or they're leaving, it's specifically because of the laws?
Yes. I was actually just reviewing physician engagement raw comments from our survey last year, and it's de-identified, so I can't tell who's writing the comments, but I can tell you that the physicians leaving are an even more broad group than OB/GYNs and maternal fetal medicine specialists. So it also has tentacles that have impacted the broader physician workforce.
What other areas of medicine are affected?
Well, I mean, specific to this, as the maternal fetal medicine docs are impacted, the OB/GYNs and family physicians and even nurse midwives who practice in rural areas, begin asking questions about whether it's safe to do what they do. Mm-hmm. The presence of a maternal fetal medicine bench is why you can manage a high-risk pregnancy, mm-hmm. from 100 miles away. And I would also remind all the viewers that OB/GYNs don't just deliver babies, as they also provide the health care for the reproductive organs. And the population growth that we're expecting, we are expecting greater growth in the over 60 population. Those women are going to need gynecologic care.
It's not just women of childbearing age.
That's right.
Dr. Kasper, You're in the thick of it as a practicing OBGYN in Canyon County. How has the situation changed for you over the past couple of years?
So how we take care of patients has remained unchanged, but the things we have to think about and navigate through have increased. And that's been an interesting experience in a field of medicine that is already complex. When you're taking care of pregnant women and you have two patients, the mother and the fetus, it's always more complex than just a single patient, and there are always things. It's a constant conversation. This is the information that we have at this point in time. We're going to do this. We're going to see what happens. Things are going to change, and now there's this extra layer of, okay, what am I allowed to do? What am I not allowed to do? Am I going to get? Maybe I'm not worried about getting myself in trouble, but am I going to get someone else in trouble? Am I documenting this adequately? There's more layers for some of the, especially early pregnancy complications. And then the other piece that it has been a big impact is the availability of maternal fetal medicine. You know, we're very careful now about who we refer to maternal fetal medicine. And sometimes it's a call to say, hey, this is what I have. Do you guys need to see this patient, or do you want to just, you know, give me a little bit of guidance over the phone? Because I need them to, when I have a mom with a baby that's got a lot of problems, you know, we do an anatomy ultrasound and we find some problems that baby has, or a mom with a really complicated pregnancy, I need to know that they're going to have space on their schedule to see those patients. And so it's, instead of just sending a referral off, it's now a multi-step process for us.
So that increases your workload. Ultimately, how does that affect the patients?
So the effect directly to the patients, I think we have so far been able to mitigate that. You know, it's us as providers that end up being that safety net. You know, we work more hours, we see more patients, and we work very hard to do that safely. I work in Canyon County, based in Nampa, and in our health district, which includes Canyon County, Owyhee, Payette, Adams, Washington, and Gem counties, that population for the population of reproductive age women that we should have, that we have in that area, we should have somewhere between 30 and 40 OBGYNs in that area. As of 5 p.m. tonight, with Salzer closing, which is one more in a list of a lot of closures we've had in the last year and a half, 2 years, we will have 11 FTEs of OBGYNs in that area. Less than 1/3 of what we should have, and that is calculated off of an even lower staffing ratio than what Susie quoted a few minutes ago. So we've been able to manage, but in the back of our minds, we're all thinking, all right, how far can we take this with how many of us there are and how many women need to have care before the wheels start to fall off?
And this is all in Southwest Idaho, in broader Treasure Valley, proximity to Boise. Susie, what are you hearing from the more far-flung rural hospitals?
Right. Well, we know we've already had 2 hospitals close their labor and delivery units. And so there is a real access to care problem, especially in our rural areas where women are having to travel further to get care that used to be provided in their home communities. And that means folks are waiting longer and perhaps having to drive in dangerous winter conditions. But as Dr. Souza mentioned, it also has a ripple impact on the community for access to care for women and families in general.
And Dr. Souza, you have St. Luke's in Boise, but you also have other facilities in Wood River Valley and in Twin Falls and elsewhere. What's the landscape like in those rural communities versus in Boise?
Yeah, the impacts there go beyond access to women's services, and it's because of the fact that these systems of care are highly interdependent. So just two examples I would give. First, part of the reason a rural hospital is able to pencil it out to provide anesthesia services is because they deliver babies. As the OBGYNs go, then the labor decks go. And when a labor deck closes, now a rural hospital administrator who might be operating on a pretty small number of days cash on hand has to ask, can I still afford my anesthesia team? Do I have enough other surgical volume to sustain that, or do I need to walk away from that? The other example is a more concerning one, I think, and it has to do with just primary care access. Family physicians who choose to practice in rural settings tend to be physicians who really want to practice full spectrum family medicine, which includes care of children, care of adults, and obstetrics. If they're contemplating going to a community that no longer offers a third of their spectrum of care they've trained in or passionate about providing, that's going to be an impediment to recruiting those physicians to those rural communities, which then has a bigger impact on care of kids and adults in those communities.
Ultimately, we've been hearing about physician shortages, especially in rural communities, for years now, long before the overturn of Roe v. Wade.
Yes.
Susie, what could the legislature have done to address some of these concerns this year?
We were really hoping coming into this session to be able to pass a maternal health exception to the abortion ban to provide some more clarity for Dr. Kasper and others in knowing when they can intervene and when they have to refer patients out of state. And unfortunately, with legal issues of Idaho's law being heard at the U.S. Supreme Court, that kind of put a brake on any legislative pathway for us this year. I think for us, regardless of what the Supreme Court rules later this summer, we feel we still need a health exception to help allay some of that uncertainty and fear on the part of physicians and on the part of patients, and make sure that pregnant women in the state of Idaho who are experiencing some complications can get the care they need when they need it in their home communities.
And just to emphasize real quick, there is currently an exception only for the life of the mother, not for the health of the mother and not for the life of the fetus.
Correct.
So, and that priority for further legislative steps came directly from feedback from physicians, both physicians like me who are still practicing in the state, and also some of the physicians who have left, who have said, yes, if there was language that allowed for treatment of medical emergencies, not just someone who's actively dying, that would have made me comfortable enough to stay.
And I think that's also been echoed by potential recruits as well, because the entire nation is facing a shortage of OBGYNs. And so when they are looking at Idaho versus other states, I think several candidates have said, if we had a maternal health exception and more clarity in the law, that makes in Idaho a more attractive place to look at. But right now we don't have that.
Can you give us any sense of how those talks with lawmakers went?
Regarding
potential changes to the law?
I think we left the session last year having made a little bit of progress towards a partial health exception. Unfortunately, we weren't able to cross the goal line as far as making that happen. And I think most legislators that I've spoken to are in favor of making sure that pregnant women experiencing complications can get the care that they need. Political dynamics are part of the legislative process, and all we can do is keep telling our story and highlighting the pressures for physicians and the impact on patients.
In the meantime, Dr. Kasper, do you anticipate this getting worse in the next year?
I do anticipate it getting a lot worse. I am coming to this from the perspective of someone, I don't do terminations. I have never done terminations. And so my perspective on some of the restrictions that I'm now experiencing are not terribly dramatic. It's more for me to think about, but it doesn't keep me up at night. That doesn't keep me up at night. What is starting to keep me up at night is the evolving maternity care desert in my own community where I work and practice. With Sulzer's closure, and I work for Sulzer, I am opening my own practice, and part of what got me over the fear hump to do that was realizing our practice had 440 actively pregnant patients, and I knew there was no way for those women to get, all of them, to get absorbed into the existing practices. And so if I was going to help prevent care gaps, the only way I was going to be able to do that fast enough was to open my own practice. And I can't take care of all of those women with just me and my colleagues that are joining me, but it's at least a chunk, and then it's a piece, and that does keep me up at night. We need more help. We need more help to take care of Idaho moms.
All right. Thank you three so much for joining us this week.
Thank you.
Thank you.